Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be going over diabetic complications. If you haven't done so already, guys, please don't forget to like and subscribe. Like this video, subscribe to this channel. I covered diabetes in its entirety. Besides this one, I think it may be about 4 or 5 videos, so make sure you guys check that out. This video, we're going to go over the complications. I have audio lessons available for you on my website, nexusnursinginstitute.com. All right, guys. I got my plug-in. Let's get started. So the first let me make this bigger for you. The first complication that we're going to go over is angiopathy. So let's take a look. It says chronic complications associated with diabetes are primarily those of end organ disease from damage of the blood cells. And let me stop right there because I want you to think about it, guys. What is supposed to be in the blood vessels? Blood, right? Blood that's carrying the oxygens, the vitamins, the nutrients, the minerals, all that good stuff. But the patient that has diabetes, the sugar that's supposed to be going to the tissues and feeding those tissues and cells, they're stuck where? In the blood. So I want you to think about all that sugar being stuck in the blood, in those blood vessels, turning that blood that's supposed to be moving nice and freely, right? Turning it into something thick as molasses, thick as honey, thick as syrup. That's that same thick blood because of all that sugar that's supposed to be feeding your brain, that's supposed to be feeding your kidneys, your pancreas, your liver. Do you see where I'm going here? Okay, so diabetes, you better believe it's going to affect every single organ in the system. Now take a look at what it says. Angiopathy is one of the leading causes of diabetes-related deaths, with about 68% of deaths caused by coronary vascular disease and 16% caused by strokes for those ages 65 or older. Now take a look at this figure. Make sure you know this. These are the biggest organ complications you will see in a patient that has diabetes. And I highlighted the ones that tend to show up the most on NCLEX. But guys, I don't write NCLEX, so everything is fair game, all right? Look at this, stroke. I don't know why I didn't highlight stroke, because stroke definitely is one of them. Where's my highlighter? Anyway, stroke, hypertension, nephropathy, kidney damage. Look at this, diabetes is the #1 cause of end-stage renal disease. Peripheral neuropathy. And this is why, you know, I did that whole teaching on foot care and making sure that the water's not too hot. The patients tend to lose feeling, you know, in their lower extremity, in their fingertips. And so it may be easy for them to get infection, not even know it, or be burned and not even know it. Peripheral vascular atherosclerosis, blindness. Again, #1 cause of blindness in the US is from diabetes. Cataracts, retinopathy. Retinopathy is another one I should have highlighted because that shows up on NCLEX a lot as well. So make sure that you guys are very familiar with this figure and you understand that these are definitely complications of diabetes long-term. Monitoring for long-term complications of diabetes. So for the retinopathy, very important. You're going to teach that patient to get their eyes checked at least what? Annually. Okay. Nephropathy, make sure they're getting their BUN, serum creatinine checked, glomerular filtration rate. Neuropathy, remember that patient will have foot and lower extremity loss of feelings. So you're going to teach that patient to check their feet every single day. If they can't, have somebody do it for them. If they can't reach down there to see, use a mirror. But it's very important that their feet is checked every single day. Cardiovascular disease, they need to be going in for physical every year. Risk factor assessments, they need to be checking the blood pressure. They need to be checking that patient's cholesterol. They're going to be looking at the triglycerides, the AST, the ALT, that liver function. Smoking, that patient needs to be taught, stop smoking, not slow down, stop completely. family history of premature artery disease. They need to be assessed for that. So guys, make sure you take a look at this. Very important teaching. Now let's go over the macrovascular complications. Let me see if I can make this bigger for you. Okay. So macrovascular complications, these are diseases of the large, and that's why it says macro, large and medium-sized blood vessels that occur with greater frequency and with an earlier onset in people with diabetes. So these are things that can happen to the patient earlier in diabetes versus, for example, your end-stage renal disease, where the patients had that diabetes for a long time and they end up getting the end-stage renal disease, okay? Macrovascular diseases include cerebrovascular accident, that's a stroke, cardiovascular, your heart, and peripheral vascular disease. Patients with diabetes can decrease several risk factors associated with macrovascular complications, such as, guys, they're giving you the list. This is a beautiful select all that applies. Hint, hint. You need to know this. What are those examples? Obesity, smoking, hypertension, high fat intake, and sedentary lifestyle, being a couch potato, not getting out there and exercise. Smoking, which is detrimental to health in general, increases the risk for blood vessel and cardiovascular disease, stroke, and lower extremity amputation. Okay? Something else is very important, treating that hypertension, because that long-term hypertension can lead that patient to get what? A stroke, okay? A stroke, organ failure, a target blood pressure of less than 140/90 is recommended for most patients with diabetes. And most of your textbooks say the normal range is 90/60 to 140/90. For these patients with diabetes, we want to keep lower than 140/90. Now, like I said, guys, each book is different, so the numbers might differ a little bit. So I'm giving you that range, but go by the textbook that your school uses. However, for testing purposes, with NCLEX, you know it or you don't. They're not going to give you a very large, no, actually back up. They're not going to give you a very small margin. It's going to be a blood pressure range way out. So you either know it or you don't. So whichever book your school's using, just go by that. You'll be fine for NCLEX, I promise. The American Diabetic Association recognizes that diabetes by itself is a risk factor for cardiovascular disease. So simply being diabetic, that within itself is a risk factor for heart disease. Therefore, it recommends that all adults with diabetes take a statin. What is a statin? A statin is a drug that lowers cholesterol. The fact that you are diabetic, that makes you a risk factor for heart disease. So automatically it's recommended that you take a statin. I wrote something on the side. What did I write here? Oh, an example I gave was simvastatin. Those statin meds end in statin. If you haven't watched the video, the pharmacology video I did on statin meds, make sure you guys catch that. Very important. The ADA advocates lifestyle interventions, including, I keep telling you guys, when you're seeing these examples, make sure you know them. These examples make beautiful select all that applies. So what are those examples of lifestyle changes? Nutritional therapy, exercise, losing weight, stop smoking. I didn't say slow down. I said smoking cessation. Stop smoking. And all of that will help lower that cholesterol. Hyperlipidemia, that's what they're talking about, high cholesterol. Okay. The ADA also recommends blood pressure screening at every routine visit for people with diabetes. Every single time they go into the doctor's office or they see the nurse practitioner or they see the PA, whoever the healthcare provider is, they need to get their blood pressure checked. Blood pressure screening at every routine visit for people with diabetes. They also recommend lifestyle advisement for blood pressure greater than 130/80 and treatment for blood pressure greater than 140/90. And remember, we want to keep that blood pressure for diabetic patients less than 140/90. Now let's talk about small, microvascular complications. Microvascular complications result from thickening of the vessel membranes in the capillaries and arterioles in response to conditions of chronic hyperglycemia. That sugar in the blood makes the blood so thick. Guess what? The thicker that blood gets, the more force is going to be pushing against the vessels because it's trying to get through those vessels. What is hypertension? The force exerted against the vessels? Duh, it makes sense, guys. It makes sense. They differ from macrovascular complications in that they're specific to diabetes. That's the difference. Okay. Most noticeably affected are the eyes, retinopathy, and that makes sense. Look how tiny those vessels are going to be in your eyeballs. Okay. Retinopathy, kidneys, that's your nephropathy, and nerves, that's your neuropathy. You need to know those three for your microvascular complications. All right, let's talk about retinopathy. We're talking about the eyeballs. In non-proliferative retinopathy, the most common form, partial occlusion of the small vessels in the retina causes microaneurysms to develop in the capillary walls. That's your non-proliferative retinopathy. Okay, now let's talk about proliferative retinopathy. In proliferative retinopathy, the most severe form, it involves the retina and vitreous. When retinal capillaries become occluded, nothing's getting through, the body compensates by forming new blood vessels to supply the retina with blood. It's trying to prevent you from losing your sight. Okay, so you have, we call it, oh my gosh, what's the word I'm looking for? Collateral. They're collateral roots. That's what they make, okay? So a new blood vessel to supply the retina with blood, a pathological process known as neurovascularization. And those are the new pathways that the vessels make trying to survive, trying to supply oxygen, vitamins, nutrients, minerals, everything that your eyeball needs so you don't lose your vision, okay? Without treatment, more than half of the patients with proliferative diabetic retinopathy will be blind. Remember, proliferative is way worse than non-proliferative. Proliferative is a severe form. Interprofessional care, what are we going to do? Patients with type 2 diabetes should have a dilated eye exam by an ophthalmologist or specially trained optometrist at the time of diagnosis and every year after. Why? Because the risk is so high of them going blind and losing their vision. A person with type 1 diabetes should have a dilated eye exam within 5 years after the onset of diabetes and then repeated annually. Okay, Professor D, well, why such a difference? Why the patient with type 2, they need to get it immediately, but that patient with type 1 within 5 years? Well, remember, that patient with type 2 diabetes, remember, type 2 is what? Insidious. It's sneaky, it creeps up on you, right? So by the time a patient has been diagnosed with type 2 diabetes, they've usually been living with it for a couple of years. So it makes sense. Where your type 1 is acute, right? It's not something that sneaks up on you. Type 1's acute. So usually when that patient's diagnosed, it just happened and they have that time versus that patient with type 2. Okay, so that's a good way for you guys to remember it. Let's talk about nephropathy, we're talking about the kidneys. Diabetic nephropathy is a microvascular complication associated with damage to the small vessels that supply the glomeruli of the kidney. Let's stop right there. This is the third time I saw them letting me know that with diabetic nephropathy, this is a microvascular and not a macrovascular complication. You need to know the difference. It's a leading cause of end-stage renal disease in the US, and it's seen in 20 to 40% of people with diabetes. Patients with diabetes are screened for nephropathy every year with random spot urine collection to assess for albuminuria and measure the albumin to creatinine ratio. Remember, guys, albumin, which is a type of protein, those bad boys are big, okay? They're not supposed to be getting into the urine. The only time you'll find them in the urine is if the kidney functions decrease, because remember, the kidney is supposed to be the gatekeeper. As soon as that albumin, that protein gets to the kidney's supposed to say, I can't release you, go back into the bloodstream, okay? It's not supposed to be found in the urine. Keeping the blood glucose levels in a healthy range is also critical. Look at that word, guys. Remember, I gave you a list of words. When you're studying and you see those words, you better stop and pay attention because it's very important. Isn't that one of those words? Critical, important, essential. Keeping blood glucose levels in a healthy range is also critical in the prevention and delay of diabetes-related nephropathy. All right, let's move on to neuropathy. Now we're going to talk about the nerves. Diabetic, diabetic neuropathy is nerve damage that occurs because of the metabolic derangements associated with diabetes mellitus. We still talk about neuropathy. Managing blood glucose is the only treatment for diabetes-related neuropathy. What did I tell you about all-inclusives? When you're studying and you see those all-inclusive words, such as only, always, never, pay attention. This is telling you we have no other option. The only way that we can decrease this is what? Controlling that blood sugar. That's our only option. Make sure you know it. Autonomic neuropathy. So autonomic neuropathy can affect nearly all body systems. Oop. This is important for you guys to know. Diabetes can affect sexual function in men and women. And let me tell you something. I tend to see this has more of an effect, if a patient is being close to being diabetic. We just see that hemoglobin A1C, it's normal, but it's slowly creeping up. And they don't want to make any lifestyle changes, especially when it comes to men. When you tell them that diabetes can affect their ability to, oh, you can't see me when I do this. I was making a muscle like yeah. When you tell that man that they may lose their ability to do that, oh, they're going to start exercise. They're going to start eating salads. They're going to start eating right. Because I teach this all the time, especially in pharmacology. Nothing can make a male patient more compliant than them knowing that they won't be able to. Okay. So this is very important. Teach the men and women that it can cause sexual dysfunction. Neurogenic bladder, this can develop as a sensation in the inner bladder wall decreases. Well, what does that mean? That means that how normally you have a full bladder, you can feel it and you have to go. Well, with neurogenic bladder, they can have a full bladder and not realize it. And that can cause what? Urinary retention. Patient with retention has infrequent voiding, difficulty voiding, and a weak stream of urine. All right, let's talk about complications of feet and lower extremities. And this type of complication is the one that I tend to see the most on testing, the most. Okay, so you need to know this like the back of your hand. People with diabetes are at high risk for foot ulcers and lower extremity amputations because that foot ulcer can start off just as a small cut. But remember, that patient has diabetic neuropathy, so they don't even realize that there's a cut. And bacteria sets in and starts to fester and fester and fester. Before you know it, that infection goes to the bone, and we have no choice. It has to be amputated. Okay? Sensory neuropathy and peripheral artery disease are risk factors for foot complications. Again, how many times have we seen smoking? Smoking is deleterious. Did I say no, I said it wrong. Deleterious. You guys see the word. I'm not going to try to pronounce it, but I'll tell you what it means. It means harmful. Okay. You guys know I can't pronounce anything to save my life, but smoking is harmful to the health of lower extremity blood vessels and increases the risk for amputation. That's why you tell that patient it's not enough to slow down on your smoking. You need to stop immediately. And if you're a diabetic and you never smoked before, don't start. Sensory neuropathy is a major risk factor for lower extremity amputation in the person with diabetes. Loss of protective sensation, which means that patient, they can't feel anything down there. You know how something's wrong, you'll feel pain, you'll feel something's wrong. That patient doesn't feel it, okay? Loss of protective sensation often prevents the patient from being aware that a foot injury has occurred. So they will have a cut and not even realize it. So they can't clean it off. They can't put antiseptic ointment. They can't protect it. And then it just sits there and festers. Improper footwear and injury from stepping on foreign objects while barefoot are common causes of undetected foot injury in the person with loss of protective sensation. And that's why we teach a patient to never go barefoot. They always have to protect their feet. They always have to wear well-fitting shoes. Do not go barefoot. That is a very important teaching for the diabetic patient. Signs of peripheral arterial disease and peripheral artery disease. Let me stop there because I gotta make sure you guys understand what the peripheral artery disease. Those arteries in the peripheral, like the lower extremity, when there's a problem with the blood, the oxygen, the vitamins, the nutrients getting to those tissues of the lower extremity. That alone places that patient at risk. So you guys have to know what that peripheral artery disease is. Remember, the arteries, that's what's bringing the oxygenated blood to the tissues. Patient with peripheral artery disease, they're not getting enough of that oxygenated blood to those lower extremities, okay? Signs of peripheral artery disease include intermittent claudication, that pain that they have when they're moving, pain at rest, cold feet. Well, guess what makes your skin nice and warm? The blood. So when they're not getting blood flow to that lower extremity, instead of the skin feeling nice and warm, it's going to be cold, cool. Loss of hair. Well, think about it. It's the oxygen and vitamin and nutrients in the blood that makes the hair nice and long, right? So if the patient has peripheral artery disease and they don't have enough of that oxygenated blood going to the lower extremity, the hair is going to fall off. It's not being fed. It makes sense. Loss of hair, delayed capillary filling. Why? Because we don't have enough of it going down there. And dependent rubor. This is redness of the skin that occurs when the extremity is in a dependent position. Very important for you guys to know. The disease is diagnosed by history. They have a history of it. The ankle brachial index and angiography. Those are the top tests we'll do for it. Management includes reducing their risk factors, start eating right, start exercising, stop smoking, especially stop smoking, decrease cholesterol intake, keep your blood pressure down, okay? Bypass or graft surgery is indicated in some patients. In the patient who has the LOPS, which is that loss of protective sensation or peripheral artery disease, aggressive measures must be taken to teach the patient how to prevent foot ulcers, because it's these foot ulcers that turn into these severe infections that the patient ends up having to get something amputated, all right? These measures include the selection of proper footwear. These are examples, select all the apply, guys. Proper footwear, protective shoes. Teach a patient to carefully avoid injury to the foot. Practice diligent skincare, nail care. Inspect the feet. How often? Every single day. Inspect foot daily and treat small problems promptly. A small cut for a normal patient that does not have diabetes is a huge problem for diabetic patients. So look what it says, treat quote unquote small problems promptly. A tiny little cut that needs to be addressed because it could turn into a big problem tomorrow. Proper foot care is critical, essential, muy importante for wound healing. Proper foot care. All right, let's talk about skincare. Integumentary complications. So diabetes related dermopathy, those are your skin complications. So initially, the skin can be scaly, then they're flattened out and they become indented. Okay, we tend to see in the patient with diabetes, we tend to see these skin lesions, and the skin lesions, they tend to be like reddish brown with patches. Okay, so initially we're going to see that they're reddish brown, they're scaly, then they flatten out and they become indented. They appear most frequently on the shins, but they can be found on the front of the thighs, the forearm, the side of the foot, the scalp, and the trunk. This is important. I don't know why I didn't put a star next to it because this is all over NCLEX. Let me see if I can find a pen. Oh, I have one with me today. Okay. Acanthos nigricans. This is a manifestation of insulin resistance. Make sure you guys Google it to see what it looks like. Okay. But if a patient has not been diagnosed with diabetes and you see that on their neck, you see that on them, that patient needs to be assessed further. You need to let the healthcare provider know. Foot care. Oops. Let's go for foot care. This is important. I got lots of stuff for foot care. You're going to teach a patient to wash your feet daily with mild, not something harsh, not something irritating, mild soap and water. But before they do that, what's the first thing they have to do? Test the water temperature with the elbow. Why would they do it with their elbow and not with their fingers? Remember, they have what? Peripheral loss of sensation. So if they use their finger, they may not feel that the water's too hot. So that's why you're going to teach them with their elbow, because they lose feelings in the periphery, okay? Teach them to pat the feet dry gently, especially what? Between the toes. And as students, you guys tend to get this confused. We want to keep the feet moisturized because if the feet is dry, it can cause cracking. Cracking can cause what? Opening of the skin where bacteria can come. So we want the feet to be moisturized, right? But not between the toes, because between the toes, if we keep lotion between the toes and we don't wipe it, that can cause ulceration because there's no ventilation between the toes, all right? Teach them to examine the feet. How often? Daily. How many times have we seen this? At least 5 times every single day. And if they can't do it, use a mirror or have somebody do it for them. Use lanolin on feet to prevent skin from drying or cracking. Just remember, we don't want that. But look at this. Do not apply between toes. Between the toes can cause ulceration, maceration. We don't want to see that happen. Use mild, not severe, not irritating, mild foot powder on sweaty feet. Why? Because a sweaty feet can cause maceration. It can turn into ulcers. We want that feet to be moisturized but dry. So if the feet's sweaty, use mild powder. Cutting toenails. You're going to listen. As a nurse, you're not going to cut their toenails. That you're going to tell them they need to go to their podiatrist for them to be cut. But they can cut their own toenails. What do you think, they're going to go to their podiatrist every month, every week to cut their toenails? No. So they're going to maintain their toes or have a family member or someone do it for them. As a nurse, you're never going to do it. But when you're teaching them, you're going to teach them to cut their toenails straight across. This is very important. Make sure you guys understand it. As a nurse, you never cut a diabetic patient's toenails. But the diabetic patient, they can cut their own toenails. They don't have to wait to go to the podiatrist. They shouldn't wait to go to the podiatrist. They cut their toenails straight across. Do not cut down corners. That's how the patient can end up getting ingrown toenails and cuts and all other type of issues. So they're going to cut straight across. They're going to file straight across. Teach them to stay away from open toe, open heel, high heel shoes. The whole point is we're trying to protect the feet. We want the feet and toes covered. And that's why no thong sandals. We don't want anything between those toes, okay? Do not go barefoot. They need to protect the feet. Inspect socks and shoes for foreign objects before putting them on. Why? There might be a pebble inside of that shoe or inside of those socks, and the patient can't feel it, and they're walking all day, and that pebble's rubbing up against their foot, right? And before you know it, they got an opening in the skin, and bacteria has set in. So they need to inspect that shoe or that sock before they put in their feet. Wear clean, absorbent cotton or wool socks or stockings. Why? Because it will absorb that moisture. Remember, we don't want their feet wet. We don't want them, their feet sweating all day. We don't want maceration to occur. Do not use hot water bottles or heating pads to warm the feet. Why? They don't have feeling down there, or the feelings decrease. They may have a burn and not realize it. Avoid prolonged sitting, standing, and crossing legs. Let me put a star next to this because this shows up so many times on NCLEX as well. Why? Remember, that patient has what? Peripheral artery disease. There's already decreased circulation down there. Okay, do we want blood just sitting there pooling, now putting them at risk for a DVT? Absolutely not. So guys, this table on foot care, make sure you know it. Press pause if you have to re-go over them, because lots of questions come from this table by itself. All right, infection. Oh, I talked to you about that. Here it goes, infection. A person with diabetes is more susceptible to infections because of a defect in the mobilization of WBCs and impaired phagocytosis. Remember those phagocytosis, that's when those WBCs just eat up those pathogens, right? So impaired phagocytosis by neutrophils and monocytes. And don't forget, bacteria loves wet, dark, sugary environments. So that's a perfect medium for like in a diabetic patient. They're at risk for infections and fungal infections such as your Candida albicans. You're going to teach patients to prevent infection by practicing good hand hygiene. Avoid exposure to individuals who have communicable illnesses, and getting their annual influenza and pneumococcal vaccine. I put a star next to it because that's all over NCLEX as well. Remember, NCLEX is very big on primary preventative measures, teaching and vaccinations. Okay. I think, yes. So this is the last thing we're going to go over. Can you believe it took what, 6, 7 videos for diabetes by itself? But this is the last thing we're going to go over for diabetes, and I am done with this segment. So teamwork and collaboration, role of nursing personnel, RN. Remember, the registered nurse is going to be doing the evaluation, the initial evaluations, the initial assessments, the initial teachings. The LPN can come behind the RN and remind the patient, remember, the nurse said XYZ, XYZ. When I say nurse, I mean registered nurse, because the practical nurse is a nurse as well. But the initial assessment, the initial teaching, that comes from the registered nurse. And that is very important for you guys to understand delegation. That first assessment, that in-depth assessment is going to be the registered nurse. Now, the nurse practitioner. Now, the practical nurse, the LPN, of course, if the LPN is caring for that patient, they're going to assess the patient. You're going to assess the patient at the beginning of your shift. You're going to assess the patient before you give a medication. But what I'm saying is the initial is going to be the RN. Assess for risk factors for pre-diabetes, type 1, type 2. Teaching the patient caregiver about self-management of diabetes mellitus, including how to check their own blood glucose, how to take insulin, how to take the oral anti-diabetic agents. All of that, that first teaching is going to be from the registered nurse. Developing a care plan. The registered nurse is the one that develops the care plan. The LPN follows the care plan, but making that care plan, that's a responsibility of the RN. Again, assessing for complications, the RN. The LPN is going to continue that assessment, but initial assessment is going to be the RN. Teaching again, okay? Now, role of the LPN. They're going to give the routine medications. If you get a test question and something's acutely, actively going on with the patient that's not good, there's been a change for the worse, the RN has to keep that patient. The LPN is going to keep the most stable patient. They're going to give the most stable, routine meds, okay? So the LPN is going to give the oral anti-diabetic agents. Look at this word, routinely. And this word right here makes the difference on many, many test questions. When you're trying to figure out who gets this, the RN or the PN. If it's something routine, the PN can do, but if there's something acute that's going on with that patient, the RN has to keep it. Monitoring the patient for symptoms of hypoglycemia, DKA, HHS, the LPN can do. Initially, the RN does that first one, but the LPN keeps it up. And reporting concerns. Any changes or concerns, the LPN is going to report that to the RN. UAP, the unlicensed personnel, such as a PCT or the CNA, they're going to check the capillary blood glucose. Yes, they're allowed to check blood sugar. It's a finger stick. They are allowed to do it. They're not allowed to analyze it, but they're allowed to record and report. They take that blood sugar, they record it, and report it to the nurse. Report changes in the patient's vital signs. Okay. And guys, that is it. We are done with this segment for diabetes. If there's anything you feel like I missed, I didn't go in depth enough, or you just like to see more of, please let me know in the comment section. I'm not sure what my next lesson is going to be on. I've got a list. Please, if there's anything that you'd like to see me cover sooner than later, let me know in the comment section. Don't forget, guys, I have audio lessons available for you on my website, nexusnursinginstitute.com. And I cover questions during the week on my social media platforms, such as TikTok, Instagram, and Facebook. Thank you for watching this video, and you guys will see me on the next video.